So I'm Kerry Broderick. I'm from Denver Health, and I'd also like to thank the sponsors, ACEP. I'm on the program committee, so I'm glad to see this. Hopefully we'll have another session like this next year, and NIDA. I do have a disclosure to make. I'm currently part of a SAMSHA grant. I'm blessed with it, so it's really a program implementation. I am a clinician, not a researcher, really. I've just been blessed by being able to implement programs. And I want to thank two of my mentors, Dr. Ed Bernstein and Gail D'Onofrio, who had to step out and say goodbye to her son. But I am a nurse, become physician, much like Gail, and realized early on in my nursing career, what the hell are we doing? We're telling people all about their cast care and their stitches, and we're not seeing a word about the fact that they were intoxicated when it happened. I mean, what the heck's going on down here? And so I became interested in it a long time ago and really have been blessed to have great mentors and to be here today. So it was interesting when Chris was talking about, MI versus interrogation. It really makes me think a lot about coaching versus mentoring. And I learned recently when I was doing a faculty development thing at the university, most of us in the room are great mentors, which is, okay, where do you want to go? How do I get you there? This is what we should do. Versus coaching, which is really listening to the person and trying to move them there. And a lot of us are not very good coaches. So I'm glad we have health educators and people that can train us to do it better. So I'm at Denver Health, which is in Denver. It sees about the people that we reach, 55,000 in the ED and another 25 in the urgent care center. And over the past 6 years, we've brief screened, which is the 5 kind of brief questions, 5 or 6, depending on where we're at and what we're trying, about 420,000 patients with the brief screen. For the more in-depth screen, of which we use health educators, we've done about 80,000 of those. So our rate of screening positive screens is much higher at Denver Health. We're an inner city hospital, and I don't know what Gail's population, but our rate of positives is a good 33%. At least a third of them are positive for something. And so, to me, when I first got involved with this, was sustainability from day one. Because, when you get programs, right, you get it and they give you the money. They're like, okay, you should have screened about 30,000 patients before today. Okay, you got your money. Let's go, go, go. And there was a lot of pressure to actually have the health educators do all the screening. And I said, no, I don't want the money then. I mean, we have to build this into some type of the workflow so that at the end of this grant, there's something left. We're asking at least the brief screen questions, particularly the alcohol one or the quantification. Just that question alone changes behavior. So sustainability, if you get involved with it, you have to think sustainability from day one. It's just so important to think about that. I can't say that I had the buy-in or sustainability initially, but I did insist on that. Administrative support. If you're trying to do a program like this and administration isn't behind you, forget it. You're going to have all kinds of battles. And particularly in the emergency department, when I say administrative support, it's really the nurses. They're in charge after all, right? They decide what's going to work and what isn't. So you really have to get nursing buy-in. So administrative support from nurses, but the nurses themselves. And build it into the workflow so it just becomes the usual. This is what we ask. We ask this every time. Is your tetanus up to date? How many drinks have you had in the last week? Have you ever had a problem with drugs or whatever your questions are? And find champions. There's a lot of new faces in the room. I was thinking about that today. So a lot of us have been around for a while, right? So we're the same old champions, same old faces. I've seen Chris for years and Ed. But there's a lot of new faces in the crowd. There's always champions. You just have to encourage them, just like we got encouraged, I think, early in our career. So you got to find champions in the department, too. There's always people that are ready to step up and help get this going. Of course, educating the staff and the nurses why it's important and how to do it, that's without being said. And also partnering with the billing department. You have this thing going on. Now there's billing codes. You've got to start day one with the billing department so they understand it, because billing and compliance go hand in hand, and there's a lot of that going on when you build a program. So you want to make sure you partner with them and get what you can so you can keep the program running. You can sustain it somewhat with your billings. Now, who does it, right? So who's going to do it? That's always a fight when you start a program. So who's going to do it? Is it the nurses, the healthcare partners, which are aides, providers, health educators? Every shop is different, as Ed was saying. You have to work in the system you're in. In our system, we built it into the workflow so the nurses ask all the brief screen questions up in screening. That's in the ED. In the clinics, that didn't work so well. It's the healthcare partners, but they ask that every time when the patient enters. They ask those questions. And in some places, social workers do it. But you have to figure out what works best for the system. For us, it's the nurses at screening or the healthcare partners, and they do the brief screen part of it. So they ask those 5 brief questions. So Who's going to do it all, though? So you ask the questions now, do I really have to do it? Well, like I said, in our system, we figured out the brief screen the nurses could do, or the health educators, and the full screen wasn't really going to happen in our system. A full screen meaning we use the assist. That's what the first grant started with, and so I've kept that so that we can actually keep going with the same data that we've had for years for comparison. And the full screen is the assist. No, there's no way that the health providers will do that. So we actually use health educators to do that, and we're blessed. So when Ed was talking about it before, I will say that in the last grant, in Colorado, of the 12 sites, the 12 centers that had this program, 10 of them, the hospitals kept that program on and hired at least one health educator, because at the end of the grant, they felt, we can't let this person go. This has really made a difference in our department and our patients. And I think that's telling. 10 centers kept it going. And at Denver Health, because we're so busy, the hospital has funded 2 of those. So 2 of them are hospital funded full-time. Where does it get done? So that also depends on your system. Does it get done in triage, in the room, electronic and registration? We've talked a lot about that. I don't think there's a right or a wrong place. I will say anecdotally in our system, we tried to do it a little bit in medical screening. And what we found, and we do look at the nurse brief screen questions too, is that when the patient's in the room, we get much better answers from the patients. Now, part of that might just be because it's the emergency department. So, you know, they come there because they have chest pain, or they come there because they have a headache, and somebody's asking them about their drug use and whether they smoke. And they're like, I really don't want to talk about that. I came here today because I have chest pain. So it's a no, no, no. But in the room, they seem to be much more forthcoming. So once they get into an examination room, they know their room, the doctor's going to be in, or the provider, they seem to be much more honest in the room about actually what's going on. So it seems like that the brief screen in the room correlates much better to the assist. So for us, it works better in the patient room rather than before they get roomed. This is just what we built into the system, just to show you the questions that we ask. It goes right after suicide risk assessment. There's the brief screen questions. And pretty easy, so it self-scores it. We have an internal IT now, and I have an emergency physician that does all our kind of IT for the emergency department, so I'm lucky in that too. We're going to go to Epic next year, and then it'll be a hassle, I'm sure. So I'm looking for some mentors about how to build it into Epic for meaningful use. So this one, it self-scores, and this one is a positive, so this person smokes tobacco and has had more than 4 drinks. And up on our tracking board, it pops up as a positive SBIRT screen, so the clinician knows right away they're positive, and somebody should talk to them. Let's figure out what their brief screen is positive for. But how do you train them in sustainability and training? We've talked a little bit about that. So when most programs start, there's a lot of, you know, in-person, face-to-face training, trying to get the nurses up, the docs up. It takes a lot of time. It costs a lot of money. And how do you keep it going? New staff all the time in the emergency department, in the clinics. Now you got to train people every 3 months, every 5 months. So I think you need to think about that when you start a program. And we actually, you know, like all of you, probably have the things that Gelden Offra was talking about before. You know, you take your yearly little test for the hospital, and you go to the bottom and you take the test and figure out what you got going. But we have a module, but the module's interactive that our IT people built in, so that you can't actually go through the scenario with the patient unless you click on it and read what they have to say. And it also doesn't let you auto time out, like click, click, click. You actually have to sit there for a minute and read what the person says. So when any new staff member is assigned to the areas with SBIRT, they get assigned this module. So they come on, they get assigned the SBIRT module. They have to take it within the first 3 months, like all the training programs. And so that worked for us. But you can outsource it. There's internet. There's all kinds of ways to do it. Peer assistants, who I work with very closely in Colorado, who really runs the SBIRT grants, and we're one of the sites. They have developed a SBIRT mentor for training. They're charging about $200, so that's costly. Some places can't afford it, but there's CME built into it as well, and they also use scenarios and some interaction. It's a pretty good module. So you can outsource it. There are things you can use. But you got to keep it going, right? So we built it into the annual nurse credentialing that all your nurses do. So once a year they have to do skills day, skills session. We built SBIRT right in there. So they have to actually take a skills session on SBIRT, how to ask the questions appropriately, why is SBIRT there. There's also built in a couple little scenarios of patient modules. And like I said, IT assigns it to all new hires. Tracking was an issue when when we were grant funded. Of course, we had this nice database they uploaded to. But so when we were getting ready to finish the grant about a year before, I went to one of our bigger partners in the emergency department, trauma service. right? Trauma service is mandated to do this. So I went to the trauma service and said, look it, every time that you report your statistics for how much SBIRT screening you do, you use my numbers, because I'm the only one that's doing it, and that's fine. But I need some help. I need to build a database, because we need to link all the patients we screen in the emergency department and then all of the trauma patients. And then we link them together. So a monthly report tells them how many of the trauma patients that they've actually screened with SBIRT and how many were missing. And so it's a pretty easy, it's just an access database. You probably all have something in your hospital that you could use, somebody there that could help you do that. And we use iPads. Our health educators use iPads, and then they just upload the data, and then we get reports. So that's how we did it. So we have this simple database, and then billings. I have a monthly billing report. So using the E&M codes and CPT codes, the billing department gives me the facility charges every month, as well as the pro fee charges, and I can look at that to see how we're doing. And it's a pretty easy report to run. Administrative reporting, also, you want to keep a program going, you got to keep your administrators happy. So my trauma guy will give me a nice little graph and some reports that I can hand to the administrators to show them what they're paying for. So this is what you're paying for, this is how many people we've screened, this is how many people we've referred to treatment. And super bill codes, I mean, in all your clinics, if you have clinics off-site, so we have a lot of FQHCs, federally qualified health centers. And in almost all our clinics, we have super bills, so we got all the coding on all the super bills. That was pretty easy to do once you get talking to your billing and coders. And then you can track it through all that. Even if you don't bill, if you decide not to bill, you can talk to your services and have them at least check the box if you provide the services without billing the patients. And if you don't want to bill them and you want to decide that later, you can do that.
Dummy codes.
This is our database. It's a pretty simple database as far as what their score is, and it's a click, click, click. That's the billing report, pretty simple. I've taken out the identifiers. We don't get paid very much. We have, I don't know if it's worth running the billing report some month, but we have a lot of self-pay, a lot of CICP, a lot of prisoners, and all of that's bundled in. But of course, once we have the Accountable Care Act, you know, maybe that will make more of a difference about the services you provide and what you end up getting overall outcomes. So you really want to prepare a compelling case to administration. When I was getting ready to end the grant 2 years out, I started to work on this with the billing people and also the finance people at the hospital. But what I quickly learned was that when you add up the figures, especially for a lot of inner city hospitals, the financial case is going to make it. When you look at the numbers, truly you're never going to probably build a program off the numbers, off of getting paid, unless you're in a system that has pretty good payers. So you got to have the human pitch too. You have to really talk to the administrators about this is our population, this is our community, this is the right thing to do, you know that's the right thing to do. And then you know, need some pilot data about how many people screen positive, who's in the moderate group, which is really the group that SBIRT is designed for, so baseline screenings. But you also need to get some financial patient demographics, some billing and reimbursement data. And you do need a financial person to assist you with that to build your case to your administrators why you should be doing it. And I was able to sell it, so they took on 2 health educators, and I'm thankful I still have them. So that's really what I have at Denver Health, and I'm blessed to have it. Thankful to be here. So thank you.